slice, this is the incus. So, for cochlea, longest cochlea with long cochlea, the bone found, it is the incus, malleus, and for vestibule and the vulva, this is the incus and the
resolution
again, next our semicircular canal. Lateral semicircular canal can be seen in different views and different styles.
resolution বাড়াবো
Here, lateral axial view.
না
This
resolution
is
বাড়াবো নাই
lateral semicircular canal. This is signatory. In the coronal
lowest
view,
resolution দিয়ে
here this is lateral semicircular canal superior, and this is the vestibule. So, if any erosion is found, if the hypodense, this two hypodense area, if missing the hypodense area, here if miss the hypodense, you can say there is erosion in the lateral semicircular canal. Again, this is the signatory. So here, this position and this slice and this slice, we can look for is there any lateral semicircular canal erosion. If we go for the superior semicircular canal, again we can for superior semicircular canal erosion, this coronal section is very important because this area superior, this is the superior semicircular canal, arcuate eminence is here. In some cases, congenitally, some semicircular canal may have the dehiscence, may have. So, if there is any loss of intensity, we can say there is should be have the there may have the dehiscence of the superior semicircular canal. Again, this is the superior semicircular canal, lateral, and this is the posterior. This is the superior semicircular canal. Here, you can see this is the posterior semicircular canal, this common crus, and this is the superior semicircular canal, ampullary canal. So again, the posterior, just I have mentioned different specific pathology, specific structure, how we can see in different slides. That's why same slides came in different times. Again, posterior semicircular canal we can check here, axial and coronal. This here is the posterior semicircular canal. Here is the posterior semicircular canal. This is the posterior semicircular. These all are coronal, and here is the posterior semicircular canal. So, when you check the DICOM format, this is a specific area you will look for. Just it is mentioned the specific site, right? We should look for. Now the facial nerve. Facial nerve you can appreciate in axial and coronal view. Different slides we can see the facial nerve. First slice, this is the internal acoustic meatus. And from the internal acoustic meatus, facial nerve is entering into the medium. This is the labyrinthine part, labyrinthine segment. Here is the genicular ganglia, and this is the mechanic segment. This is the GSP. This is the GSP. So if some card, if the card is like this, then you will see the long axis of the facial nerve and the eyes of the two eyes is here, medial and lateral. Medial one is the labyrinthine segment, lateral one is the coming later. Again, here This is the facial nerve, lateral semicircular canal. Here it touches the lateral semicircular canal. This is second facial nerve, tympanic segment. Again, in the coronal section, here this is the facial nerve, chorda tympani, at pyramid, sinus tympani. So this is the facial
Facial
viscus.
viscus.
This is the facial viscus where we do the posterior tympanotomy. And this is important for the doing during posterior tympanotomy in case of especially cochlear. So,
Coronal section.
just I mentioned earlier, this is the longest is the cochlea, and this is two eyes. See, this we call snake eye appearance. Medial one, the labyrinthine segment. Lateral one is the tympanic segment. If there is loss any hyperdensity, then we can say the tympanic segment of the facial nerve is dehiscent. Again, here if the hyperdensity is lost, we can say the tympanic segment is dehiscent. So this is the coronal section, and this is the vertical segment of the facial nerve. Here again, this is the lateral semicircular canal. Just in the enter inferior to the facial lateral semicircular canal, there is a spot. This is the second this tympanic segment. From this point, vertical segment starts, and the tympanic segment ends here. This is the where we can check the round window niche. Very important in case of cochlear implant. So if we can, sometimes it is seen for different surgeons. They start the posterior tympanotomy. After doing the posterior tympanotomy, round window niche could not be seen but could not be found, because there is some limitations, or may have the limitations, or may have some anatomical variations. So you have to check before doing the surgery. This is the round window niche area. Here, this is the round window niche area. Sometimes in the sinus tympani area, there may have some large cell, may have the high jugular bulb area. Sometimes there is a solid bone covers the round window niche area. Recently, I have operated one case. It's very difficult to find out the. This is full round window area was covered with a solid bone. So if we don't have the adequate pathological or abnormalities knowledge, then we cannot find this problem can solve. So again, the cochlea can be seen in different ways. For cochlear implantation, this figure and this figure is very important, because in a whole
Cochlear turn.
we have to look for, is there any ossification, is there any calcification. So these two, this is the basal turn, middle turn, and apical turn, and this is the whole length of the cochlea. So cochlea can be seen in different ways. And this picture is really another important picture. This is the axial view. This is the internal acoustic metas, cochlear aqueduct, basal turn, middle turn, apical turn. Because if in case of radiology, if we see the cochlear aperture is not adequate, you can say this is the hypoplastic cochlear nerve or absent cochlear nerve. So it is important to look for these views. Again, so I'm doing a little rapid. Dural position or treatment position is very important for planning the surgery. Hey, sir. How we can assess the position of the technique? look this picture. This is a from this picture we can easily assess the position of the dura. This is the scutum, and this is the head of the malleus. From the scutum tip and along the head of the malleus, there is a vertical line up to the dura. Again, from the scutum tip, there is another 10 millimeter lateral points. Here again, there is a vertical line. If the first line, this is A and this is B line. If the first line is shorter than the second line, this is
low line to
found the dura is low line. If this first line is taller than the second line or equal, then we can say this is the normal tegment plate. Another way we can assess the lateral semicircular canal is very important landmark for the assessing the tegment plate. So here you can check again. This is the lateral semicircular canal, and this is the arcuate eminence. So if there is a transverse line, this is the position where the root of the zygoma is here. So if we make a vertical transverse line, if the lateral semicircular canal line to the arcuate line is shorter than the this position, almost nearer to the lateral semicircular canal, then we can say this is the low lying dura. But this previous slides, it is very easy to find out the lateral semicircular, tegmental position. So another thing is sigmoid sinus and jugular bulb position. In many cases, we found the sigmoid sinus anteriorly placed to jugular bulb higher, but we have to assess where is it anteriorly placed or it is higher. If we see the jugular bulb area almost touching the promontory or round window niche, then it is said high jugular bulb. Sometimes the bone over the jugular bulb found dehiscence. There is a loss of hypertensity. And how we can assess in a normal vision, it is seen, we can say this is the anteriorly placed, but we have to have the normal landmark. How we can say this is the anteriorly placed? Look, this is the posterior semicircular canal. If we draw a line along the long axis of the posterior semicircular canal, if the sigmoid sinus position is anterior to the long axis, then it is said it is anteriorly placed. If it is along or behind the
মিলন হলে তা না মিলন হলে দিলে সমস্যা ওখানে প্রোগ্রাম না না স্যার খুব সুন্দর.
So this is the another landmark for selecting for mentioning the position of the sigmoid sinus. Very important. We can easily look for anteriorly placed inward sinus. This
এই
is
তিনটা
the
লাইন তো
landmark code. Posterior semicircular canal, long axis of the posterior semicircular canal. There is
সামনে
line,
থাকলে।
draw a line. If it is anterior, then anteriorly placed. If it is along or posterior to the line, this is the normal position.
স্যার বাকি তিনটা বিশাল লাইন ছিল আর এত সুন্দর একটা লেকচার না অনেক কিছু নতুন দেখতেছি না
So another important thing we have to find the position of the internal carotid artery. So internal carotid artery, we know just anterior inferior to the promontory, there lies the internal carotid artery. And when we manipulate the institution tube area, be careful. Sometimes it is seen the internal carotid bony shell of the internal carotid may have the dehiscent. So during manipulating the institution tube area, because it is lies anterior-inferior to the institution tube area and the anterior to the promontory. This is the internal carotid artery. This one is internal carotid artery. This is the vertical segment and this is the horizontal segment. And this is the, here is the institution tube. So this should have the, before going to surgery, we should have looked for. Again, this is the coronal section. This is the internal carotid artery. We have to check.
মাথা উপরে তুললে কেমন হয়
Already I have mentioned the facial recess area. So facial recess area can assess in the coronal axial section. Again, this is the chorda tympani. This is chorda tympani nerve. The posterior semicircular canal. This is the vertical segment of the facial. So this is the facial recess and this is the sinus tympani. So everybody, internal acoustic meters, you can see different segments, different slides. This is the axial and coronal segment we have to know. For in case of cochlear implant surgery, this internal acoustic meters diameter is important. If we sometimes we have seen the internal acoustic meters is very narrow, then we can say here may have a aplasia or absent
Clear nerve.
internal
Cochlear nerve.
nerve. Oval window area so oval again oval window in the mostly in axial coronal view oval window or footplate of the stapes can be seen very easily, but in case of coronal section we can just can see where the oval window shadow. This is the stapes anterior cora. This is the posterior cora. This is the interstitial joint, and this is the malleus. So in this picture, we can easily assess the presence or absence of the stapes superstructure. So we have to look for this. The sinus tympani area again. There is a diagrammatic saying it is called W. First peak is the promontory. Second, first deep area, this is the sinus tympani. Second peak is the pyramid. Second low lying area is the facial recess, and second peak is the posterior wall. That is where the chorda tympani lies. So now the tensor tympani muscle. Here, how we can say find the tensor tympani muscle in the CT scan? Look, this is the axial view. Here, this is the promontory. See. Internal carotid artery, eustachian tube, just anterior superior, superior to the eustachian tube. There is the tensor tympani muscle. It comes just superior to the promontory. Where this is the processus cochleariformis. Here, from the processus cochleariformis, the tendon is going to the neck of the malleus. Earlier, I mentioned two dots. These two dots, neck of the malleus and the long process of the incus. So, from this processus cochleariformis is seen, the tendon is going to the neck of the malleus. It is already mentioned.
Two dots line, two horizontal line.
Now the vestibular aqueduct. Here we can find the vestibular aqueduct. There is the posterior semicircular canal. Just behind the posterior semicircular canal, there should have the vestibular aqueduct. Sometimes it is wide, sometimes it's very narrow. So there is a indentation area. Just this is a sigmoid sinus. Here the endolymphatic sac is here. Just posterior to the semicircular canal and just anterior to the sigmoid sinus. And again, this is the posterior semicircular canal. Here is the vestibular aqueduct. Again, this is the posterior emissary vein. Anisur mentioned in his lecture, So the posterior in case we before doing surgery, we can easily see the position of the posterior semicircular canal. In a classical canal wall down mastoidectomy or vertical mastoidectomy, the posterior limit is the posterior emissary vein of the mastoid cavity. So this is the posterior emissary vein. It is going to the sigmoid sinus. It is already mentioned. This is mentioned. So this is the where I tried to mention the specific structure in which slides we can see. Now I'm going to আচ্ছা আমি জাস্ট এটা এখানে জাস্ট আমি একটু ডায়াগ্রামটা আমি একটু দেখাই দিতে দেখতে পাবেন যে কত ইয়েতে দেখতে চান অথবা আপনি এটাকে দুই আঙ্গুল দিকে ক্রল করে আপনি এটা পাওয়া যায়। এই এক্সিয়ালটাকে আমি করোনালে কনভার্ট করতে পারি। করোনালে কনভার্ট করে সেম স্লাইসটাকে আমি করোনালে কনভার্ট করে আমি এটা দেখতে পারি। এখন আপনারা এইটা যখন আপনি ওই যে পয়েন্টগুলোকে আমি দেখালাম, তো ওই পয়েন্টগুলো যদি আপনি স্পেসিফিক এই ডাইকম ভিউটাতে মানে তাকান ওই পয়েন্টগুলো, তখন আপনি স্পেসিফিক স্ট্রাকচারটা ওইভাবে দেখতে পারবেন। কেউ যদি চায় আমার কাছ থেকে এটা কপি করে নিতে পারেন। আমি আর এখানে ডিটেইলস জানি না, আমাদের সময় হলে অনেক কম, জাস্ট আমি একটু দেখানোর জন্য। থ্যাংক ইউ ভেরি মাচ।